Day 3 at EuroPCR. And my name is Darren Mylotte for Radcliffe Cardiology, and I'm delighted to be joined today by Professor Ruiz from New York and Professor Pepe Zamorano from Madrid, and we're going to discuss briefly left atrial appendage closure and imaging for same. Professor Ruiz, you've recently been using the Philips Heart Navigator for implanting these devices. How has that changed your practice?
Well, we don't have per se a practice because none of the devices are approved yet in the United States. But yes, it has really modified the way we do procedures by using the fusion imaging technology. The pre-acquired CT not only allows us to prepare and plan the procedure ahead of time, orientation, access site, and device size, but then you can bring that into the cath lab, fuse it with the fluoro. That volumetric rendering gets fused, and it's a good landmark for us to follow at the time of the procedure. Of course, you need to confirm that with the real-time image information, and that's what Dr. Zamorano spoke about with the echo, which is what gives us the real-time feedback.
So there's a new kid on the block. There's a CT and fusion imaging. Most of us who have been doing these procedures are used to using 3D and two-dimensional echocardiography. Where do you come down on this subject?
Well, the good thing of echo is that you can do it real time inside the cath lab, so you can really help the invasive cardiologist. Well, 3D is a must because it really shows you the anatomy, the left atrial appendage as it is. And the fusion image is how can we better speak to each other. So it's the same language, so the invasive cardiology will see in real time the merge, the fusion of the angio plus the information coming from the 3D echo.
Excellent. One thing we've learned from transcatheter aortic valve replacement is in terms of sizing. We know that echo sizing is probably not as accurate as 2D echo sizing is not as accurate as CT. And we also know that when we look at the left atrial appendage, the same is true, that on CT studies, the landing zone tends to be 1 to 2 millimeters greater on CT than with invasive echocardiography. How do you size?
I think it depends on on how you use these technologies. And if you're using, for example, curve MPR for the CT, where you get very clear definition of the center line of the structures, and then you do perpendicular planes to that, you will not get it wrong, you will get it right. But you will get it right for that single phase. The cardiac cycle is a long cycle, and there is a lot of variations, especially in the left atrial appendage. So I think at the end of the day, the echo 3D will give us a much more reliable information at the time of implant than the CT. But the basic sizing approximation, I think, is more accurate with the CT than with the 2D echo.
Dr. Zamorano, a final word?
Well, I think that 3D is really the answer, because 3D, don't forget that the left atrial appendage is a volume. So 2D is not the answer, because 2D echo makes mistake, because 3D, the atrial appendage is a 3D structure. So maybe we will need to move to areas instead of diameter of the ostium, and this is the answer is coming from 3D echo.
Excellent. So hopefully we can look forward to better planning, simpler procedures, and better outcomes for our patients. Thanks for joining us.
Thank you very much.
Thank you.